Good afternoon, everyone. A very warm welcome from all of us here in the Faculty of Science and Technology at the University of the West Indies, Mona campus in Jamaica, to all of you who are viewing in Jamaica, the wider Caribbean, and the world. A very special welcome to the students in the audience, those of you who are from primary schools, secondary schools, and or university students who have an interest in science and who want to use it as a tool for solving problems like COVID-19, or who are just here to get inspired so that they can get better grades in science. I want to welcome the policymakers and the business leaders and encourage all of you to make your contributions to this discussion, as science must hold hands with policy and business before it can create wealth and impact lives. To other members of the public who are using this as an information session, we say welcome. Please feel free to share your thoughts, as you are important stakeholders in the UWI, and FST, the Faculty of Science and Technology, values your partnership. The COVID-19 pandemic is the worst global crisis since World War II, and it currently threatens to eliminate the social and economic advancement that many countries, including Jamaica, have enjoyed in recent times. However, like it has done throughout history, scientific knowledge is guiding humanity through these unprecedented challenges, from characterizing the virus and sequencing its entire genome, to understanding how it is transmitted and how we best protect ourselves from it. Science is fulfilling its classical goal of building knowledge and understanding, and its modern mission of solving problems and making people's lives better. The UWI's tradition of excellence has earned our triple first ratings. We are in the top 1% of universities in Latin America and Caribbean. We are in the top 1% of Golden Age universities in the world, and we are the only Caribbean university to be ranked in the world rankings. The Faculty of Science and Technology here at UWI Mona has played a pivotal role in establishing the UWI as a world-class institution, as it stands front and center, advancing the mission of science to make people's lives better. This afternoon, as part of our Science for Today Forum series, we are talking Fighting COVID-19, Science in Action. This is round 1 of 3 rounds, with the second coming to you on August 5th and the final round on August 12th, 2020. This afternoon, we open with an impressive lineup of 6 contributors from the UWI and its agencies. I invite you to participate by posting your comments or questions and interacting with the speakers in the live chat, which is being moderated by my colleague, Dr. Kimberly Stevenson. Now I present our first contributor, chairperson of the External Engagement Committee on which I serve, and which is responsible for organizing this series, Dr. Andre Coy. Dr. Coy lectures in the Department of Physics here in the Faculty of Science and Technology. He holds a BSc in Math and Electronics, an MPhil in Climate Physics from the UWI, and a PhD in Computer Sciences from the University of Sheffield. He previously worked at McGill University, University of Sheffield, and Barnsley Hospital NHS Foundation Trust. His research interests include automatic speech recognition, machine learning, artificial intelligence, and assistive technologies. His work has led to the development of a portable speech recognition and text-to-speech device to aid individuals with speech impairment. As Associate Dean in charge of external engagement in the Faculty of Science and Technology, Dr. Coy is involved in a plethora of outreach activities which promote science and its applications to society. Remember, ladies and gentlemen, I said our faculty was front and center in advancing the mission of science. Well, Dr. Coy will expand on that with a presentation entitled The Faculty of Science and Technology and its Capacity to Respond to COVID-19.
Thank you, Dr. Singh-Wilmot, and good afternoon, ladies and gentlemen. We are living in extraordinary times, and it is at times like these that extraordinary people step up and show an impact on the society that they're living in. And I want to share with you today about the Faculty of Science and Technology's response to COVID-19. The University of the West Indies has a mandate to drive and to sustain the development of the Caribbean region. And so we believe that the Faculty of Science and Technology is the go-to place for science knowledge, research, and solutions. In fact, we are convinced of it, and we want to convince you here today. So what do we offer as the University of the West Indies Faculty of Science and Technology? Science is our core function. As such, we have 6 science departments that consist of chemistry, computing, geography and geology, life sciences, mathematics, and physics. We also have 5 science centers, institutes, and units. These are the Biotechnology Center, the Center for Marine Sciences, the Natural Products Institute, the Earthquake Unit, and the Mona Institute for Applied Sciences. We have over 50 science majors and minors. We have 30 taught and research graduate programs. We currently have 2,807 undergraduate students registered and 354 graduate students. As well as the excellent teaching and learning that we do, we also have a strong track record in science research. Caribbean science is our core product. One of the areas that we excel in is in agriculture and bioscience. Here we do crop modeling, yield projections and predictions. We study where varieties will grow and how well they will grow there. We do plant protection through the identification of plant viruses, nematodes, and harmful bacteria. Using drones, we also study disease prevention. We look at improving post-harvest processes, as well as pest management. We excel in climate studies. We do research in Caribbean climate variability and dynamics. We look at historical and projected regional, national, and subnational climate change. We have climate portals available where we provide tools for decision making. We look at climate impacts, impacts on the economy, livestock, water, health, and the marine environment. In the marine sciences, we excel at studying coastal life and the causes of potential degradation. We look at protected areas, fishable stocks, seasons, and we study all of these at our marine laboratories. We're studying the sargassum seaweed. We look at monitoring, prediction, collection, and uses, including for bioenergy, agriculture, the anti-cancer properties, and for bioplastics. We study coastal nurseries, looking at mangroves, the replanting techniques, and coral reef rehabilitation. In the natural products arena, we study the potential of Jamaican and Caribbean natural products to impact our societies. We look at the safety of our natural products. We investigate the interaction of natural medicines with prescription medicines. We also investigate the use of natural products and their derivatives for their potential in cancer prevention and their properties. We also look at mosquito eradication studies. In the geosciences, we excel at geomapping. We've currently mapped over 70% of the geology of Jamaica, and this has highlighted also the fault systems that exist on the island. We monitor earthquakes, and we do research in the seismic hazards in Jamaica. With disaster risk resilience, we are developing tools for mitigating disaster risk. One such tool is the FEWER app, which is an early warning system for the marine environment that fishers can use to determine what is happening in their environment and be warned if there's a disaster or some other event that is happening around them. We provide analytical solutions. We look at air and water quality management. We look at pesticide residue determination. There's a plethora of work being done in the food chemistry area, and we also study mineralogy. In computing and electronics, we look at computer intrusions, forensics, and the exploitation of software security. We look at complex systems modeling using robotics and system automation. In the machine learning area, which is very current, we look at using artificial intelligence in diagnostics and problem solving, as well as other areas such as speech recognition. We look at the effects of wireless device on human health. We do software engineering research, web animation, visualization, and e-learning. These are some of the things we do in the Faculty of Science and Technology. Now, how have we used all of this capacity, all of this expertise in responding to COVID-19? There are many things that are being done in the faculty, and I will highlight a few of them. We've been looking at environmental monitoring. During the lockdown period in Jamaica, we looked at several aspects of the environment, and we monitored them in order to see how lockdown would have affected these aspects of the environment. Several questions were asked. What were these impacts? Are these impacts sustainable? Can we maintain the good effects that occurred during lockdown? And what can we learn from the lockdown experience as we move forward in our efforts to protect the environment? There's geospatial mapping that was being done in the British Virgin Islands. Workshops were held to assist the BVI social development team. The mapping assisted in visualizing regions where the most vulnerable citizens are to be found. This exercise assisted in the planning for the delivery of care packages to the most vulnerable in that society. In the biotechnology natural products arena, the Natural Products Institute contributed to a global study on the impact of COVID-19 on ethnobiology, which is essentially the study of how people interact with all living things. Several questions were asked. How will the pandemic affect indigenous communities and their traditional knowledge, their subsistence, and the management of their natural resources? How will the global crisis affect interactions between researchers and local communities? Beyond that, NPI is also doing research on the potential for natural products in the search for therapeutics for COVID-19. In disaster risk management, we are looking at redefining the COVID-19 crisis. COVID-19 is the largest public health crisis to face the world in modern history. The researchers at the UE are asking a question: should this be considered a crisis, or should it be reclassified as a health disaster? This reclassification would allow for a change to the management of the crisis, which would be modified so that some of the most vulnerable would be given more attention. In artificial intelligence, there's a multidisciplinary team that is now competing for a grant to develop AI-driven approaches to the COVID-19 response and recovery efforts. The project would cover areas such as optimizing patient diagnosis, care and recovery, forecasting transmission and reducing spread, using AI to support gender inclusivity and COVID-19 response. These are some of the areas that the FST is exploring in the fight for COVID-19. But given all of the expertise that exists, given the capacity that exists within the faculty, there is certainly more to come. How can we further leverage all of this strong track record of impactful research to increase our response to the COVID-19 crisis? We can further develop our data analysis and machine learning applications through our high-performance computing cluster, a Sparks supercomputer. We could also further develop the mobile applications for contact tracing, local infection monitoring, and spread prediction. Ladies and gentlemen, I hope that I have convinced you about the capacity of the Faculty of Science and Technology, not only to deliver science to our students, not only to do research which is beneficial to our faculty, but also to do research which is impactful to the society, to develop applications that are going to help us during this crisis and as we move forward. And so I will end where I began. The Faculty of Science and Technology is the go-to place for science knowledge, research, and solutions. Thank you.
Thank you very much, Dr. Coy. I stand proud after that talk as a member of this team of researchers in the Faculty of Science and Technology. You have shown us that science and scientists create, Science solves problems, and that certainly right here in Jamaica, we have the capacity to do it right here on the Mona campus. The FST is certainly the go-to place for science, knowledge, research, and solutions. Now, testing is such a critical component in the COVID-19 fight, but there is so much that the public does not know about the screening process. Our second contributor, Dr. Sandra Jackson, will be demystifying COVID-19 screening for all of us, and she is well suited to do this. Sandra Jackson is a medical microbiologist, a clinical virologist, and a public health consultant. She has earned the degrees of MBBS, DM, and MPH from the University of the West Indies and has worked with UWI for over 20 years. With an interest in influenza, Dr. Jackson acted as director at the National Influenza Center for Jamaica for 15 years, following which she joined the World Health Organization Global Influenza Program in Geneva from 2015 to 2019 as a consultant virologist. Her research interests include viral respiratory infections, pandemic preparedness and response, emerging viral infections, and the standardization of WHO global respiratory virus surveillance. Ladies and gentlemen, Dr. Sandra Jackson.
Good evening. Thank you for that introduction. And I would like to thank the Faculty of Science and Technology for inviting me to speak on demystifying COVID-19 screening. As we move forward and progress through the pandemic, we need to understand how we proceed and what the next steps are with regards to surveillance and the role of screening as this will play in the mitigating the spread of the pandemic and controlling it. Many studies have shown that approximately 80% of persons have mild infection or are asymptomatic, with about 20% progressing to moderate to severe disease. In those that progress to moderate to severe disease, there is a very wide spectrum of pathogenesis and that occurs associated with the disease, including a cytokine storm. They have associated coagulopathies with it, and also right now hyperinflammatory responses, particularly in children. Prior to the onset of symptoms, there's a pre-symptomatic phase in which the patient will present with symptoms that are very similar to that of flu and any other acute upper respiratory tract illness. So it's difficult to differentiate the patients who are presenting such as with a common cold or with flu in the pre-symptomatic phase. Surveillance so far has targeted patients that are presenting to clinics or to sentinel sites, presenting with acute upper respiratory tract or lower respiratory tract infections, and also severe cases that have been admitted to hospitals, looking to identify the SARS-CoV-2 virus in these cases. Much contact tracing has taken place, contact tracing of confirmed cases, and some of these contact cases are defined as close contacts, and some are not. So not as close, but they're followed up to see if they are going to contract the disease and present as well. And then there's targeted surveillance and screening that has also occurred, in which we look for the high-risk groups that are most vulnerable to having severe outcomes and poor outcomes of the disease. Not everyone with COVID-19 feels sick, as I said. And a new report of 238 young adults, service members on a naval aircraft, tested positive for CoV-2 virus. So this clearly shows that there's a large percent of persons who are asymptomatic who are potential carriers and drivers of this pandemic. How is the virus spreading? If we look at other examples, such as the choir practice that occurred in the United States last month, in which there was one symptomatic person, and that one person infected 87% of the group of other persons who were attending the choir practice. When we look in the healthcare system, 90,000 healthcare workers have been infected so far, with more than 260 nurses dying from SARS-CoV-2. And this data is not taken globally. It only represents 30 countries. And this was published in June 2020 by the International Council of Nurses. Not only are healthcare workers getting ill, but healthcare workers within the setting also have the potential to pass on, to transmit the virus to other inpatients, hospital inpatients or outpatients, or the healthcare center. There are countries that have experienced high burdens of SARS-CoV-2 and who have dealt with it successfully. For example, COVID-19 in South Korea. South Korea's response to testing, increased testing throughout, knowing that the virus was highly contagious and that there were asymptomatic patients who were able to transmit the disease, resulted in a very positive outcome. In South Korea alone, they performed 1.5 million tests, and their result positivity of 0.9% is very good. When we compare reported cases and deaths by territory, and look at Jamaica and at South Korea, although South Korea has a population of 51 million and Jamaica that of 2.9 million, when we look at the number of tests per million population that has been done, South Korea has performed 29,000 deaths per million and Jamaica 11,000, approximately 12,000 tests per million in population. When we look at the total number of cases per million persons, in South Korea, they have reported 276 cases per million, and Jamaica 283 cases per million. Looking at South Korea, as they have opened up their borders, we see that although initially to curb the transmission of the virus, healthcare professionals, committees, governments had a combined approach, which included extensive COVID screening, effective patient triaging, transparent provision of information, and extensive use of technology. And looking at the graph here at the daily cases that have been reported recently, we see in pink what we have are the imported cases, and in blue, these are the cases that are the locally acquired cases or community acquired cases. So as they opened up their borders, you saw an increase in the number of imported cases. But strategies were put back in place to monitor this. So when we speak and we refer to surveillance versus screening, what we need to look at is surveillance of patients presenting to sentinel sites or to healthcare facilities who are symptomatic, and there are certain screening that will accompany these patients to assess the severity of their presentation. And also we're looking at screening not just clinically, but also from the laboratory aspect to confirm whether or not the case is a COVID case or one of the other respiratory infections, such as influenza. In accordance with the Jamaica National Surveillance Protocol for the surveillance of COVID-19, surveillance proceeds in a specific manner with targeted surveillance of special groups. And this includes the respiratory tract infections, as I explained on the previous slide. And these will include your ILI, SARI, or your lower respiratory tract infections. And your entry surveillance is in place currently. And this is for returning residents tourists, and business travelers. All symptomatic persons are screened and sampled at the ports of entry. Returning residents and general tourists must submit evidence of negative COVID test as a test result from a recognized laboratory before or as part of the entry process into the island. And all business travelers are screened upon arrival. When we look at the symptomatic phases, we should remember that 80% of these cases are going to recover, whereas 20% will develop or may develop mild to moderate illnesses. With these 20% that develop mild to moderate illnesses and the 80% that do recover, they are infectious. And looking at the curves, if we look at the line that's shown here that says virus, for those who recover without complications, the virus usually is eliminated by day 14. However, in those who have more severe course of infections, the virus can continue for up to day 21 and for longer periods. If PCR is done, peace polymerase chain reaction, which is a test that can detect the viral RNA, what they have found is that even there are some patients who have recovered and who are not severe, but they're still detecting virus RNA. When they try to culture this, it's not culturable after, say, 14 days. So on this, when we look at the slide surveillance of symptomatic cases, for those cases or persons who have been symptomatic, it's necessary to trace and investigate their close contacts and their contacts. And in doing so, then they're further able to classify them as probable cases or suspect cases, and with the laboratory confirmation, finally as confirmed cases. So how do we define a contact? A contact is a person who experienced any one of the following exposures: direct physical contact, which means face-to-face or direct care of a patient who is confirmed to have COVID, or 2 days before or 14 days after the onset of symptoms of a probable or confirmed case. How do we define a close contact? A close contact is someone who has been within 1 meter of a confirmed case during their symptomatic period, including 4 days before the onset of symptoms. I show you this slide, the clinical similarities and differences between flu and COVID-19, because COVID or SARS-CoV-2 is the virus, causes the disease COVID-19. COVID-19 has some presentations that are not typically seen with influenza. And also we have to remember, as summer approaches, we have allergies and also the common cold viruses, such as the rhinoviruses and other viruses that can also cause respiratory infection. So not everything is COVID. So when we look at those patients who are in the pre-symptomatic phase or prodromal phase, the virus is still present and they're still able to shed the virus and transmit the virus. There's another portion of patients who are asymptomatic throughout the time that they are shedding the virus, and they do not present with any symptoms. So both the pre-symptomatic and the asymptomatic cases have potential to transmit the virus to others. As we said, this slide is from CDC. 1 out of 5 persons reported no symptoms with COVID. The contribution of pre-symptomatic transmission to the COVID-19 outbreak has a relatively high impact. And if we look at this graph here, the pre-symptomatic cases is depicted in the pink, with those with after symptoms onset in the green. So the potentially high contribution of the pre-symptomatic transmission would be a large dent in the hope for controlling the outbreak. And it implies that limiting pre-symptomatic transmission, for example, via public health messages and encouraging self-isolation, even when mild symptoms, will need to play an integral part in controlling the pandemic. So the infectious period can be defined as a period thought to be 1 to 3 days before the onset of symptoms, with an additional 7 to 12 days after the symptoms arise. Shedding in patients with severe disease requiring hospitalization has been demonstrated to transmit or to shed the virus for up to 20 days post the onset of symptoms. So is screening necessary for asymptomatic, and how would you do this among your contacts or your close contacts and in your pre-symptomatic phase? This is a challenging question that is looked at and one of the purposes of screening. Also, we have to look at the population of targeted or high-risk individuals that will have a poor outcome in order to detect the virus early. Several studies have been done on the asymptomatic cases and reported different percentages, varying from 43%, 42%, 87.9%, 62%, 96.1%. A study in Ohio and Virginia among the inmates reported asymptomatic cases among 96%. Hospital employees, 65%. Passengers on the cruise ship, 81%. So we see the relevance of pre-symptomatic and asymptomatic cases in the control of the COVID-19 pandemic is going to be significant. So in targeted surveillance, what we're looking at are your high-risk groups, such as your elderly or your patients with hypertension, as diabetics, as these cases have been shown to have poorer outcomes. In screening and looking at the properties of a screening test, this is done usually on apparently healthy individuals, and it's applied to groups, can be applied to groups as well. They're based on criteria in which there is a cutoff for that particular population. Sometimes in terms of the screening test may be less accurate, they may be less expensive than diagnostic tests. And screening tests are not usually sometimes the basis for treatment, although there must be some kind of management protocol in place when screening is going to be introduced. When we look at diagnostic tests are done on sick or ill individuals, and they can be applied to a single patient. The diagnosis is not final, and it's based on evaluation of both the result and also the signs and symptoms, in addition to the lab findings. The diagnostic tests are more accurate. Sometimes they tend to be more expensive, such as the PCR is more expensive than immunochromatographic rapid tests, and it's used as a basis for treatment. And also the initiative usually comes from the patient who seeks medical attention. In looking at the operational considerations for the identification of healthcare workers and inpatients with suspected COVID-19 in the non-US healthcare settings, if we look at passive strategies that were used, healthcare workers were asked to self-assess themselves for fever and a defined set of symptoms indicative of COVID-19. And then if fever or respiratory symptoms were present, then the healthcare workers were asked, would report remotely this information. They did not report directly to the healthcare facility, but they were provided with immediate medical assessment and follow-up actions via telemedicine as to whether they should come in for one-on-one treatment or assessment. Using this passive strategy enables the mechanisms for identification of healthcare workers at an increased likelihood of infection, whereas it also saves on the resource requirements that are needed. If we apply this similar strategy to an operational consideration for passive and enhanced or active COVID-19 screening of students returning to university, national and preliminary screening protocols and tools should also be available for students, both at the primary, secondary, and tertiary levels. For international students, the same travel authorization and screening protocols applying to tourists should also apply to students. And also the protocols should be in place for national students. Assessments by students can be done, as with healthcare workers in the previous study, by online screening using online screening tools, and a protocol for follow-up of suspect, probable, and confirmed cases should be in place for the management. So the strategies for screening would include passive strategies, enhanced, passive, and also active strategies. So we discussed the passive strategies. So looking at enhanced passive strategies, this would include reporting alerts that are initiated by the data source with an added mechanism to prompt data collection, review, and or of the reporting. For active strategies, we're looking at reporting alerts are initiated by the centralized health authority, such as the Ministry of Health, the facility infection preventionist, and also the facility administrator, using a known set of rules and regulations. So all three can be employed at various degrees. When screening can be mass screening, which would apply to large unselected populations where everyone in a group is screened regardless of the probability of having the disease or the condition. This tends to be expensive method, and it's not done, it's not affordable in many countries. And then there is a high risk or selective targeted screening, such as we would target asthmatics or hypertensive patients for screening. Multipurpose screening refers to screening by more than one test done simultaneously on a particular case. For example, a respiratory sample is collected. It can be tested for both COVID-19 and also for influenza. We must remember that influenza still is an emerging virus, and that with pandemic potential, and it is important to detect such viruses at an early stage. And multiphasic screening refers to various diagnostic procedures used to during the same screening. For instance, with diabetes, they could use the fasting glucose and the glucose tolerance test. Looking at the tests that are done, the laboratory tests, there are certain characteristics that we should strive to have within the laboratory test or assay that is used for the screening. Presently, WHO has a list, World Health Organization has a list of recommended tests to be used with COVID for confirmatory diagnosis. And the CDC and also the Euro CDC, most of the regional headquarters and offices, reference labs, do have protocols that are available. The validity or the accuracy of the test is important in terms of knowing how many true positives there are, and this is termed the sensitivity, or how many true negatives there are, because you want a test that's going to detect when the positives, when the case is a true positive, and also have a good predictive accuracy. So we speak and we refer to the positive predictive value, which is the probability that the result of that test is going to, that has a positive, is truly positive for the disease. And the negative predictive value of the test is the probability that subjects with a negative screening test are truly do not have the disease. The cutoff point of the test or assay that is used is also very important, because the cutoff point in terms of COVID, using COVID as an example, and the PCR to detect the viral particles in the swab, if the cutoff point is too low, then you're going to get more positives than you should have. So your sensitivity would be high. If your cutoff is too low, then your specificity in terms of the number of negatives that you have will be lower. So you have a greater chance of having false positives originate when you have a cutoff that is too low. Similarly, having a cutoff that is too high will result in the opposite. It will result in a lower number of positives and a higher number of negatives, false negatives being produced. Now, which test you're going to use for your screening will depend on the type of disease, how lethal is it. For instance, in terms of you have a pandemic virus and you want to interrupt the transmission of it. So therefore, you need to determine, is it more important for you to have true positives or true negatives? With true positives, you're able to interrupt the chain of transmission. The Institute of Microbiology from Lucerne in Switzerland published this article on the diagnostic strategies for SARS-CoV-2 infection and interpretation of microbiology results. Looking at it, it actually showed the ability of the PCR to detect the virus, live virus, up to day 14, 15. But when I say live virus, this is virus that is able to be cultured after. In terms of the diagnostic serology, we see that the antibody to IgG and the IgM start to arise on day 5. Antibody to the nucleoprotein starts to arise from before day 5, actually. It arises early, that's the IgG, but then it falls off. And then we have antibody to the S protein or the spike protein that develops from day 5 onward, and it will remain elevated for some period of time. So this graph is interesting because it actually shows the different components, the antibody being developed to the spike protein, the IgG, and the antibody developed to the N protein. So looking at the slide on antigen detection, we'll ask ourselves, so in terms of the polymerase chain reaction, just a reminder that the genes that the primers and probes are targeting include the E gene, the N gene, and the RNP genes. So these three are diagnostic for COVID-19. Looking at the next slide in terms of the PCR positivity, duration of this, as I had mentioned before, in terms of days after symptom, PCR can continue. You will find, however, that the CT value may be higher than expected, but if you try to culture, you will get a culture negative sample. And this next slide speaks to that duration of infectivity of the particular positive sample. And we see that on the top row here, the culture is positive up until day 8. and then it's negative up until day 14, you will see after the onset of symptoms. So you will continue to get negative up until day 14. They should be clear. Duration of infectivity and seroconversion. We will see, as was shown in the previous slide, that the percent of seroconversion of the patients, it's approximately from day 5, looking at this graph here, from day 5, the antibodies start to be produced, the patient starts to seroconvert. Also, in terms of, although we said that the nasopharyngeal swab is the recommended swab for the PCR, there are studies that have looked at using the saliva as a viable alternative. And they actually found the saliva to be a little bit more sensitive than the nasopharyngeal swab in this study. Upper versus lower respiratory tract infections. The saliva and endotracheal aspirate, of course, an endotracheal aspirate would give you, in more moderate to severe cases, would give you a better positivity. But we can see here from this slide, upper versus lower respiratory tract, that the virus is detectable in the saliva as well. What about patient-collected testing? We've heard where there are patients, there are states, and both in Europe, Asia, and in the US, that are promoting for the patients to collect their own samples, and they would send them in to get tested. So this FDA has approved the first standalone at-home sample collection kit, and this can be used with certain authorized tests that the FDA has on its list. So there are various methods to try and improve the amount of testing that is done. And also next generation sequencing will also have a part to play in going forward in both diagnostic testing and in surveillance. Particularly, there are certain reference centers that are just going straight to sequencing now, because it would be able to tell you immediately, is it COVID-19 or is it another novel pathogen that's being detected. What they do know is that persons who have more severe infections will develop a more robust antibody response. So in accordance with the National Surveillance Protocol for COVID-19 in Jamaica, the surveillance system that is in place, we go to the next slide, we're showing you some of the representatives here from the Ministry of Health who collaborate with the Department of Microbiology, Virology, and National Influenza Center in enabling the surveillance and screening, which is to come, of SARS-CoV-2. On the next slide, I'm showing you, this is the laboratory staff that has been working behind the scenes. There you have the NIC director, Professor Monica Smykel, and her team. And these are the faces of the persons behind the mask who are working 7 days a week to get the testing done. Detailed information with regards to the targeted surveillance that is in place for the novel coronavirus is documented in the Ministry of Health and Wellness Coronavirus Disease Epidemiological Surveillance Protocol. When we refer to some of the new developments in technology for screening, looking back at these two doctors, Pagarty, and her professor looked at actually the tongue as a probable site to sample for COVID-19. And this is because the tongue has an abundant amount of ACE2 receptors on it. So therefore, they found that swabbing the tongue or scraping the tongue can give just as an effective result as doing a nasopharyngeal swab, and is less traumatic. And a new method, the method that is also being used, is actually to detect proteins, 2 proteins that are individually present in COVID-19, in SARS-CoV-2, that were not present in SARS or MERS. And these 2 proteins include CL-Pro and PL-Pro. These 2 proteins are what they look for. And it's a very simple, rapid test. It's a chemical reaction with a color change within 1 minute. If both proteins are present, then there will be a color change. When we look at the genetic characterization of the novel coronavirus, and we look at the GISAID, the genetic data that's there as of the 26th of May, we will see some information there from Jamaica. We've submitted analysis of the sequences of the COVID-19 viruses identified. And we see that within Jamaica, although there are 6 clades, different clades of COVID-19 virus that have been described at this point, with Jamaica, the clade that the viruses have been belong to include V clade and also the GH clade. So that's the V clade and the GH clade are the 2 clades to which. And if we look on the slide here, okay, the V is depicted in the red and the GH in the green, right? And we look at what is the genetic characterization of the SARS-CoV-2 virus in the UK, because we get quite a few visitors from the UK when we were opening up our borders. And we will see that within the UK, they have a mixture of clades present there, not just the VH, V, and not the GH and the V, but they also have in the UK all of the other clades present. What about in the United States? Similar in the United States, they have the GH, but they have more of the other G clades also present, GR and G, and also they have S and L including, and very little amount of the V clade, which we have here. I didn't include the slide here in Brazil. Brazil, it's more the G clade, although it's a mixture, but it's a G clade that they're seeing more in Brazil. So in summary, continued clinical and laboratory screening is necessary to minimize the morbidity and mortality of COVID-19. Both passive and active screening should be employed. Screening should be combined with continued mitigation policies for optimal control, and continued education of the public about transmission of SARS-CoV-2 is necessary. Healthcare workers require a sound understanding of the time frame to sample cases and interpretation of results according to the phase of SARS-CoV-2 infection. Although the nasopharyngeal swab is a recommended sample, research in the use of saliva and the tongue samples should also be considered. Pooled sampling is most effective in low prevalence COVID-19 populations. And presently, SARS-CoV-2 clades in Jamaica are V and GH. It is expected that other SARS-CoV-2 clades will be introduced into Jamaica as the borders open. Continued surveillance and testing will therefore be necessary to enable early detection and control of transmission. With that, thank you for listening, and I'd like to express appreciation to Professor Monica Smykel, the NIC team, the Principal of the University of the West Indies, the Dean of the Faculty of Medical Sciences, the Dean of Faculty of Science and Technology, and the Principal of UWI-Mona and the Ministry of Health for their support to the National Influenza Center during these challenging times of the COVID-19 pandemic. Stay safe and thank you.
Thank you so much, Dr. Jackson. We have certainly emerged from your presentation with a greater appreciation for the screening process. And now that all has been demystified about that, we can advance to tracking and predicting the spread of COVID-19. This will be the focus of the next talk, which will be given by Dr. Parris Lyew-Ayee Jr., Managing Director of Mona Geoinformatics Institute. Dr. Lyew-Ayee, a former head of the Department of Geography and Geology here in the Faculty of Science and Technology, is responsible for overseeing all commercial research and development activities at Mona Geoinformatics Institute, MGI, and led the development of the region's first GPS navigation system, JAMNAV. In his active research, Dr. Lyew-Ayee works on natural hazard analysis, crime and security systems modeling, road safety analysis, health systems mapping, transport systems and modeling. Ladies and gentlemen, it goes on and on. Data analytics, GPS systems, and so many others that are relevant to Jamaica, the Caribbean, and the world. The methodical and data-driven approach that the government of Jamaica has employed to successfully manage the local spread of COVID-19 has been supported by Dr. Lyew-Ayee and his team at MGI. Ladies and gentlemen, Dr. Parris Lyew-Ayee is the person to speak on the topic tracking and predicting COVID-19. Please give him a warm welcome.
Good afternoon. Thank you for allowing us the opportunity to share our experiences and adventures in dealing with COVID experiences for the last couple of months. We've had a very exciting few months that we'd like to share with you in terms of what we've been doing at the Mona Geoinformatics Institute in tracking and predicting the ravages of COVID-19 in Jamaica in particular, but generally around the world in terms of contextualizing what's happening out there. What we have been doing is looking at the cases of COVID in Jamaica, but we want to put ourselves in perspective here. Where are we compared to the rest of the region? Are we doing very well? Are we doing badly? The answer is kind of in between. We're doing better than some, like Dominican Republic and so on, but we're also not as good as other countries. Cuba is doing particularly well per capita, and other countries in the Caribbean. So we need to benchmark and baseline ourselves in terms of cases over the region. We've been seeing where we in Jamaica had the April spike in cases, and we saw something like that happen in Haiti. We see something like that happening in Antigua and different countries. We need to establish how do we compare in terms of how do we proceed in terms of analysis, in terms of tracking and predicting cases going forward. So to do this, we look at the overall ecosystem. We look at the number of direct flights to Jamaica on the left of your screen. You will see where we have regularly scheduled flights as well as seasonal flights from Europe, from North America, from South America, from Panama. All these places are coming in to the Caribbean directly. And this was early on into the cases of COVID around the world. So before we started to lock down, we started to mobilize to see what's going on in terms of the rest of the world. We had cases in Bull Bay, but a definition of Bull Bay is a little bit too general for the quarantine area. So we went and defined the different sections of Bull Bay. We're talking about 8 Mile, 9 Mile, 11 Mile, West Haven, St. Benedict's, all these different components of what we are colloquially calling Bull Bay. We need to define the area, square off the area of quarantine and begin to define what's going on. Then we had this lockdown in St. Catherine. And we want to figure out how do we look at logistics of enforcing a lockdown. So we went and isolated all the inter-parish road crossings between St. Catherine and St. Anne, St. Catherine and St. Andrews, St. Catherine and Clarendon and so on, and identify those points where people are likely to move across the border and then figure out what they're going to be doing after that. We also then looked at the CCTV camera footage across the country to look at pictures of the lockdown, pictures of the curfew at night. It was quite something to see, where you're able to see all these deserted roads at 8 p.m. and halfway tree and crossroads and Old Hope Road and so on, all these completely empty roads and so on. So it was very important that we began to see what's happening out there in the field in real time. But by none, the most exciting and most rewarding project we've ever been in my career has been working with the private sector organization of Jamaica's COVID Response Fund. They've raised over $182 million, benefited over 50,000 people in terms of giving them care packages and so on. It was a remarkable collaboration, especially with different members of the private sector, donors and so on, but also in particular the Jamaica Defense Force and the Jamaica Constabulary Force that provided extraordinary logistics and other capabilities. But this showed to me the important value of teamwork and cooperation. We were able to hand off to the JDF for them to execute their logistics and hand off to the donors to be able to gather supplies and distribute them in real time. So what this did, what we did here was to identify the 25 most vulnerable communities in Jamaica. Now this is going to be very important because these are the people who are going to be most affected by the COVID lockdown, whether or not they themselves have COVID. And it was something that we really had to pull out all the stops to get this thing right. But what it also allowed us was the identification of key groups of people right now in concert with so many different variables here. It's not enough to say we want to find the old people and that's it. We wanted to find where are the diabetics, where are the hypertensive, the disabled people, the poor people, the uneducated people, people who are subject to the ravages of crime. All of these things were put together. And in order to do that, we had to individually isolate each of these groups of people. So what you're seeing on the screen right now are the individual addresses for diabetics, for hypertensives, for disabled people in Jamaica. These are the registered people. But we're talking several 100,000 each. Identified by address, and therefore we're able now to lock in how we're going to address and handle these people. So all of this led to the development of the model, which incorporated 22 different variables. We're not talking about just the old people or just the diabetics. We're talking communities that have old people and diabetics and hypertensives and disabled and poor and uneducated, all of those things combined. So you do have several poor communities that don't make the list because they don't have a high number of diabetics or they don't have a high number of disabled people and so on. You have to have that combination for this to work. We use several 100,000 individual reference points that resulted in over 20,000 combinations of variables. And we were able then to test several dozen scenarios. What would happen if the whole country locks down? What would happen if Kingston and St. Andrews next after St. Catherine? What would happen with the individual cases of Anoto Bay when Anoto Bay went under quarantine? All of these things were being tested in real time using the model. The model is fed by the data, the mapping information, but ultimately the model is a dynamic system that allows us to begin to test scenarios in real time, whether or not you are a mapping person or not. But fundamentally, the model allows us to be data-driven in our approach and justification for the selection of communities for assistance. It frees us from the influences of politics or from people's individual personal networks or friendships. It allows accountability to the donors for them to be able to account for the spend and their involvement in a project like this, free from any kind of political associations and so on. And that was one of the most beneficial things for the project in terms of being able to be transparent and allow accountability to the many donors who are part of this project. So the top 25 communities included, and Old Harbour and Linstead topped the list. And this was before the April surge in cases. And those communities ended up being the top communities case-wise. This is before we even knew all of that. But then we began to use variables like crime, unemployment, all of those things to begin to whittle down this figure here and identify these are the communities we need to go in. JDF goes into those communities, does their logistics, deploy them using the Jamaica Constabulary Forces and the different donor agencies. And we're out there helping 50 over 1,000 people. And that was really rewarding. So this is the mapped output of those vulnerable communities. The areas in red, the communities in red, are those that we identified as areas that we need to focus on in terms of COVID relief, whether or not you had cases. So even though St. Catherine was the real overall hot spot, we knew that it was going to be a hot spot whether or not they actually had cases, simply because these places have the most number of people who are old, who are hypertensive, diabetic, poor, disabled, unemployed, and so on. And we're able now to pre-mobilize into these areas. Now, when we look at this thing in July, we identified 16 of the 25 communities are now trending downwards, and that's a really good thing for us to hear. 4 months into the pandemic and 2 months into the relief distribution, three communities are still trending upwards. We're watching those things, whether or not we need to refocus into these areas. But by and large, again, as I said earlier, we're looking at accountability and transparency. We're here trying to show that the 25 communities that were selected are being monitored right now for performance, for results, which is what we really were after here in the PSOJ program. Now, knowing vulnerable communities is one thing, but individual assets are going to be critical as well. You can be in a very low vulnerability community, but a nursing home is particularly vulnerable, whether or not you're in a good community or not. Children's homes are extremely sensitive to these things, and as we saw in April, the BPO locations are also areas that we need to watch. So we have eyes on these places. We're not showing COVID cases right now. We're just showing the location of individually vulnerable infrastructural assets right now, and to be able to say, okay, we got to focus on these areas. If you have a nursing home in Linstead, that's exponentially worse than a nursing home in the middle of Savannah Lamar or so on. Then we look at sector impacts right now. We can say, yes, schools are going to be affected, hotels are going to be affected, beaches are going to be affected. Let's see where these are across Jamaica. So we can then show you entertainment locations that will be closed down, or groceries and wholesale stores that are going to have to ramp up because people are going to be stuck at home more cooking. They're going to need food. Let's see where those are. Let's see where the emergency services are in totality. We're not looking at one or the other. We're looking at all of them combined. And then when we combine them all by community on the top right, you can then begin to see which communities are going to be most affected. You know which businesses are going to be affected. Now let's see which communities are going to be most affected. We're moving at individual property scale, going out to community scale, going to parish scale, and going backward. It's very dynamic. And it's something that we're very excited to explore, those kinds of possibilities for the kinds of responses that we want to envisage and incorporate as a country. And in the bottom right, you can see a lot of reds. Those are the individual assets in Jamaica that would be negatively affected, one way or another, by the COVID situation. So a lot of schools are going to be closed down. A lot of churches are going to be affected. All of those things are accounted for in these individual asset mapping. Nothing here so far is showing actual COVID cases right now. It's all showing the infrastructural or social, economic impacts of the pandemic. But then we can now look at the cases themselves. So this is neither here nor there. It's when we put it together. Overall, as of July 11, these are the communities that have had COVID cases. Again, Old Harbour and Linstead top the list. And we do see Greater Portmore, we do see Waterford, we do see other areas in red. But we do see that COVID has touched every single parish in Jamaica. And we now need to see what's going on. When you zoom in now on the Kingston, St. Andrew, and St. Catherine regions, you can see that this thing was all over the place. but not everywhere. And it's very important to see that kind of distribution of cases. This is distribution by community. So previously I was showing it individual assets, individual churches or nursing homes in Linstead, in Old Harbour, and so on. Those situate themselves on top of this kind of information, and then now you're able to see what's going on in the middle of the storm. So when you look at the individual cases in March, you see the cases in Rocky Point and Hayes and in Bull Bay and so on. But as we go into April, we see the boom in St. Catherine. We saw what happened with the BPO outfit in Portmore, resulting in Portmore community, Spanish Town, Old Harbour, and Linstead in particular, really exploding in terms of cases on the map. And then we started to cool, those areas started to cool off except for Old Harbour. But then we started to see cases popping up in the North Coast now. So Runaway Bay, Discover Bay, St. Anne's Bay, those areas started to pop up. And then we moved into June and we start seeing a little bit more migration to the north and to the west. And into July, we're starting to see Westmoreland and Hanover communities starting to pop up into the picture, while St. Catherine has pretty much cooled down. But looking at the difference between cases between April and March, you can see that explosion in St. Catherine. But you can also see between May and April how much St. Catherine cooled down. But other areas started to go orange and red now. Going into the next series of months and progressing, we can see that the case counts by community is really migrating across the country. It is very important not to just look at national information, national scale information, when we're trying to look at local scale planning and local scale activities. And so July to June, you can see areas are cooling off, but areas are warming up, and then you can see the cases popping up in the west, which were up until then fairly cool. We also want to look at the trends of cases. So we see through the month of March, individual communities trending up in red or trending down in green. Some cases popped up early in March and nothing happened after then, so they trended downward in March, which is a good thing. But then in April, you see everything is trending up in St. Catherine. And we want to see what's going on in those areas. What happened in St. Mary in April as well? Everybody's thinking about St. Catherine. It's not just St. Catherine. In May, you could see, again, things started to trend down in St. Catherine, but in other places in Jamaica, in other communities, in other parishes, they started to trend up. And we saw the same kind of pattern in the north and the west in June and into July, where the pattern kind of shifted. You do have smaller outbreaks here and there. But overall, for the 4 months between March and July, you can see that the north and the west are the ones that are trending upwards between March and now, whereas St. Catherine has pretty much cooled off for the most part, except for communities here and there in Hellshire, Portmore, and so on. Now, trending can be trending up steeply or trending up gently, but it's still trending upwards. And it's important to show that distribution and planning across the country. Now, what we also did were rolling 7-day cumulative totals. We could also do rolling 7-day averages or whatever, but this essentially is a map that you're looking at right now. Every single community in Jamaica is represented here. You can see the red areas, red and blue and green. Those are the St. Catherine communities that spiked in April and sort of plateaued off since then. You do see communities showing a step-like increase, which is showing sporadic outbreaks here and there over the time series. But of concern in terms of prediction would be to see what is going on closer to July and June. Which areas are trending upwards in July and June? And you can see a few communities are popping up in the latter half of the latter parts of the time series, whereas for the most part, those spikes in St. Catherine have kind of flattened out. Every single community in Jamaica is represented on this one graph, which is why it looks so busy. But you can then begin to isolate which ones you want to focus on, which one is of particular interest to you as the parish municipal councillor, or as a minister, or as a church organization, or a chamber of commerce. You want to be able to see this type of information quite easily. What we have done now in terms of prediction is quite exciting in terms of looking at the movement of people. It is one thing to know where people live. You want to know where people go and how to track it. What you're looking at right now are 35,000 what we call origin-destination pairs, where people live and where they go, in this particular case, to access pharmaceutical services. So we have 35,000 pairs right here. And the red lines are the movement of people towards or from crossroads. Blue is halfway tree. Green is Spanish Town. So you can see the movement of people and how far they go. On the inset map, you can see red is Montego Bay, blue is Mandeville, and you can see how far people go to access services in Mandeville. How far do people go to access services in Montego Bay and so on? And you can sort of begin to draw a line to show the area of influence of these people. And these are the mixing zones. Where you see Spanish Town people mixing up with Crossroad people, mixing up with halfway tree people, that's how things could potentially spread. That is how you want to see if a case, what is the probability of a case in Spanish Town reaching Mansion Hill or Morant Point. We want to be able to see what is the likelihood of these type of things here. This is by no means comprehensive, but at 35,000 pairs right now, we have a fairly large sample and an idea of where people are going and what they're doing. You do have people who go from Kingston to Montego Bay, but not on a daily basis to access services. So we're trying to get a grasp of what's going on with individual people, the vulnerable facilities, how people move, and of course the COVID cases that are sitting down on top of the entire country. So finally, we really have to look at the nature of scale. Scale is so critical because when you look at national information, it means nothing if you're trying to get a grasp of something in your parish. Then you want to look at, and we saw an entire lockdown of an entire parish, which is the largest parish population-wise. But that means nothing if you're trying to quarantine an Otter Bay, Enfield, or Dover in St. Mary. So you want to be able to drill down more and more and more, and the information needs to get more granular each time. We have to understand the nature of the space-time dynamics to look at and account for the role of the mobility of populations, but also how people mix in terms of where they go, what they do, and so on, and the type of activities and services that they access. But the final point I want to make here is the importance of contextual data. People are obsessed with primary data. You need to know the case number. You need to know the case number. I mean, if you have an alien invasion right now, I mean, what's the history for that? You need to prepare anyway. So what we have to be able to do is to try to account for which assets are vulnerable, which people are vulnerable, prepare for that. And then when eventualities happen, then you know what to do instead of when something happens, that's when you begin to prepare. So that's in a nutshell, our adventures in COVID for the past 4 months. Thank you very much for having me on.
Thank you so much, Dr. Lyew-Ayee, for your contribution and for the tremendous work that you and your team at MGI are doing, tracking and predicting COVID-19. I am sure, like me, the audience is impressed, especially with the scaling down to community and neighborhood levels, the space-time dynamics that show mobility and mixing of people. That data is powerful in allowing us to protect ourselves without shutting down economic activity. And this is commendable work, especially the section looking at identifying the most vulnerable among us. Ladies and gentlemen, the FST embraces the One UWI mission, and we join with UWI's Vice Chancellor, Sir Hilary Beckles, in reminding the public that UWI is one Caribbean university with one voice, serving people of the Caribbean and the world. We are therefore pleased to have Professor Clive Landis, chair of the UWI COVID-19 Task Force, in this forum. And now I invite him to speak on the regional response to COVID-19. Clive Landis, ladies and gentlemen, is an experienced medical researcher, and he's also a university administrator. He serves as Pro Vice Chancellor for Undergraduate Studies at the University of the West Indies, And he's also an outstanding researcher. He researches the immune system and viruses, including the established viruses like HIV, as well as emerging viruses like Zika and SARS-CoV-2. Please welcome Professor Clive Landis to make his presentation.
Well, it's certainly my pleasure to be participating in this forum of the Faculty of Science and Technology, Science in Action, Fighting COVID-19. I like the title. It seems like I've been doing this for the last few months. The title of my presentation is The Regional Response to COVID-19, and I will be taking this through the lens of the role of the Lyew-Ayee Task Force, which I am the chair of, and my substantive role in the university is as Pro-Vice Chancellor for the Board for Undergraduate Studies. When the COVID-19 virus first started circulating around the world, it was very obvious to the university that this was heading the way of a health crisis of international concern. And even before that status was declared by the WHO, the Lyew-Ayee had already put together a group of experts. And in fact, we were in the middle of a presentation on Lyew-Ayee TV called Demystifying the Coronavirus. And a panelist on that Lyew-Ayee TV presentation was the head of the Caribbean Public Health Agency, Joy St. John. And she was in Geneva, and she heard while she was presenting that the WHO had declared it as a health emergency of international concern on January the 29th. On February the 28th, we officially announced the formation of the task force, and this was before the pandemic was declared, which was on March the 11th. Basically, the way that we have operated is that we always knew that to fight this pandemic, we had to have very clear messaging, we had to have very clear information and good data sharing so that we could reassure the Caribbean as to what was happening and why certain measures were being taken. So this is the website of the task force, and you can peruse that at your leisure. This is the constitution of the task force. It was considerably larger than the Zika task force, which I also chaired. And each task force has a different composition because you're really dealing with different exigencies. So for Zika, you would have had neurologists and pediatricians and things like that. But here we were much more concerned with virologists, veterinary virologists. Of note, Christopher Ora is actually a coronavirus expert before any of us heard of coronaviruses. And we also have other virologists like Christine Carrington and Josh Anzinger. We have critical care physicians, the head of staff of the Lyew-Ayee Hospital in Mona, Carl Bruce. We have Harold Watson. We also have a psychosocial unit with members from each campus. So Wendell Abel, Khadija Khan, Maria Maynard, and Cecile Minot. I actually like this slide because every time I look at it, it looks as if the whole of the task force is just sort of illuminated by the smile of Maria Maynard in the middle. So in addition to Maria Maynard, on each side of her, we have a tourism expert and an economics expert. We also have an ethicist, and we have the leading pulmonologist, Terence C. Mungle, from St. Augustine. Also from St. Augustine, up at the top right, we have a gender expert. And finally, we have a representative from the student body, Caleb Gardner, who is from the Five Islands campus. So we have all of the campuses represented. And then we have from the center, we have Dr. Rhonda Jaipal-Ogaro, who is the head of marketing and communications, and Miss Janet Carew, who of course is head of UWE TV. So together with the content experts, we then also had the means of disseminating what we were doing. The task force's remit was really twofold. It was to coordinate the UWE's internal readiness, which we called UWE Ready, and it was to help inform the Caribbean's response. And we have aggregated the response to UWE Science, UWE Medicine, and UWE Cares. So as far as the internal UWE's readiness goes, we developed a COVID-19 management plan. We were very pleased to submit that to all of the campuses before the declaration of the pandemic and before the first case had been reported in a UWE campus country. So we were able to keep ahead of this epidemic. We also made a projection of the epidemic so that we could allow the campuses to make an assessment of whether it was even feasible to conduct face-to-face exams for the second semester. And of course, we concluded that no, it wouldn't be. And that enabled the campuses to make the decision to move everything online. In terms of policy, wearing my other hat, I also had to issue a lot of waivers. I think it ended up being 1,500 waivers for exam regulations because of the changes involved. And we also produced an evidentiary review. So we went across the evidence in the world on things like mask wearing, on things like, central air conditioning, whether they have a role in the spread, aerosol versus airborne. So we weighed up all the evidence in order to help the campuses to enable the safe reopening of business and teaching on the campuses. And of course, we know that they are open for business and opening on the 30th of August for the new semester. In terms of the response to the region, we modeled the task force on the Zika task force, which was the first time that we had put together a task force like this for a pandemic. Previously, we had task forces which would go in, for example, after a weather event like Hurricane Dorian or something. You would immediately send in the engineers, the water technicians to make sure the water supply is okay, the buildings are sound. You would send in psychological counselors, development experts. But this was the first time for Zika that we had done the same thing for a pandemic. And so we were able to really build on that model, and we had all of the contacts, and we were able to go back to CARICOM, back to CARFA, and the regional governments and health agencies and say, look, we're here, and we're here to assist. So even though the Zika approach was very collaborative, this was on a whole different level for COVID-19. So right from the first special emergency meeting on February the 4th, hosted by the CARICOM Secretary General, Ambassador Erwin LaRocque, all the way through the heads of government, the 9th and 10th special emergency meetings, several meetings of COSOD. I felt a bit like a diplomat a lot of the time, and I was also assisted by other members of the task force who would sit in on these meetings. Also the first emergency meeting of COSOD, which was actually for education, where we had a very significant role to play there. And then the Caribbean Tourism Organization and the CHTA, they had multi-stakeholder collaborations of which we were a part. And then the development partners for the Eastern Caribbean, they meet bi-weekly, and SEDEMA technical advisory meetings, they meet weekly, and we make presentations to them. So we've been very deeply embedded in the whole decision-making and the emergency response to the pandemic. And what's emerged really is UWE as a regional observatory. This is a unique role that CARICOM asked of us, and we are fulfilling it, and we're able to provide this kind of granular data on a country-to-country basis. And this is the output of the Georgia Lynn Chronic Disease Research Center. And we do this daily. So we have algorithms that capture this information, and we have these sophisticated outputs. This is a heat map showing the daily cases, and you can see that Haiti obviously has a very high caseload. They share a 400-kilometer border with the Dominican Republic, which has an explosive outbreak. You would also see that Suriname, which shares a border with Brazil, has had some difficulty with cases. And Jamaica, of course, right there around about April, it had its fairly notorious call center outbreak, but it's managed to get on top of that. You would also see that now, having reopened, that some countries like Jamaica, the Bahamas, and also St. Vincent have had a little uptick in their cases. And, this is to be expected as we open our borders. And this kind of information is going to be critical to allow us to keep on top of this. But the overall picture is really one of containment. So this is an output from the 22nd of July. And you can see that the growth rates are basically flat for all of the Caribbean countries. You would note that Haiti has the highest growth rate, but you can see that they've got on top of it and they've flattened it off. And you would see that Suriname, is struggling with their growth rates as well. And you had that flight, I think, from Antigua, where 34 persons, their repatriation flight, were positive, and there's a big uptick there. And you would notice that the Bahamas, who just recently had cases imported into Grand Bahamas, they would be, that little uptick would be noticeable since they reopened their borders. But this is basically a picture of containment. And if you wanted to be sure of this, and people might say, oh, maybe you're not doing enough testing and things like that, well, then you have the deaths that you can look at. And look at that panel on the left. I mean, really, this is remarkable. If you look at the 20 CARICOM countries, which include the 6 UK overseas territories, we haven't even had 300 deaths for the whole epidemic, for the whole region of 16 million people. This is extraordinary. And really, I would never have believed that we would achieve this remarkable containment and when we first started out. We've also published on this because, the world is very interested in what the Caribbean has been able to achieve. So we have 2 publications right now already published in Lancet Global Health and Research and Globalization, which really are speaking of this remarkable achievement in the Caribbean to contain the epidemic across a region. And if you wanted to, pinch yourself and say, well, yeah, but is this really real? Let's benchmark ourselves against countries like New Zealand and Iceland and Singapore, which have contained the epidemic. Well, here you go. I haven't shown all the countries here, but I have included, for example, Haiti, which has the biggest problem. And you can see that they still have a picture of containment, somewhere between New Zealand, Iceland, and Singapore. And they're certainly not at the level of the UK, and you will note that this is a log scale. So across the region, we have achieved containment, and the information that UE has been able to put out has been absolutely critical on a country-to-country level to allow policymakers and decision makers to decide when to open, how to open, and to guide all of their responses. And the pillars on which this containment has been achieved is really, it's almost old-fashioned good science. So it's testing. The testing has been excellent. And I would say that for every epidemic, our testing has become better in the Caribbean. Now, the last time that European countries or the US experienced a global pandemic would have been in 2009 for the so-called swine flu epidemic. But we've had the swine flu epidemic in 2009, we've had chikungunya 2013, we've had Zika 2016, and now COVID-19. And every epidemic, we've become better at testing. So whereas in 2009, there really would only have been maybe 1 or 2 labs that could have done that testing, we now have 12 labs across the Caribbean that are doing this. And we also have excellent sample collection from the RSS, the Regional Security Service. Even when Lyew-Ayee and all of the flights were grounded and cancelled, they were sending samples to the CARFA lab in Trinidad for those countries that didn't have their own lab. And if you have testing, you have to have a quick turnaround, because in that period where people are waiting for their test, they could be contacting and transmitting the disease to other people. So our contact tracing is very good here. Our isolation procedures and quarantine, all of it is good. And we've managed to protect the hospital system and the intensive care system in the Caribbean. And these are extremely quiet. They have not been overwhelmed in any way. So we really have achieved containment. So in terms of UWI medicine, here are the pictures of the health centers, UWI's teaching hospitals in Jamaica, Bridgetown, Nassau, and Port of Spain. And in some ways, we take it for granted that the majority of consultants and nurses and paramedical professionals, laboratory technicians would all have come out of the UWI system. So UWI's graduates are populating all these buildings. But we didn't really want to dwell on that. We really wanted to focus the work of the task force actually on research. So here is a piece of research that failed spectacularly, and I am so happy it failed. The WHO Solidarity Clinical Trial. So UWI is registered with the WHO to undertake the testing of existing drugs, which are against other diseases like malaria and Ebola and HIV, and to see whether they're effective against COVID-19. And do you know why our research has failed? Because we don't have sufficient patients. We don't have the patients in the intensive care sites in order to be able to participate meaningfully in this trial. So this is one piece of research where I'm so glad that we failed. And long may it last. I am confident that we are able to maintain what we have achieved thus far with very, very low levels of severe cases and deaths. And we are also contributing, as we did for the Zika epidemic, in what I would call sort of genetic detective work. And we are, of course, looking to see if there are any lineages, for example, the G614D lineage, which has been spoken about recently, whether we have that in our region. And then we feed this into global databases. And in terms of UWI Cares, I would start with the work of the ethicist Anna Perkins. And it's vital that in a new paradigm where you have persons who are making rules and imposing policies that affect the lives of whole nations and peoples, that they're underpinned with ethical principles. And the principles would be respect, inclusion, and responsibility. And if we really just focus on respect, I don't want to go through everything, we respect the dignity of all persons, recognizing the equal inherent value of each person. And that includes the right to life, which is oftentimes linked and dependent on a right of access to healthcare. And although we haven't really seen an overwhelming of our healthcare system, a lot of persons have either been unwilling or unable to go to the healthcare centers to treat existing conditions, which is a shame, because we could be getting secondary mortality from persons who have serious illnesses like HIV, cancer, etc., who are not accessing the healthcare system. So the ethicist has put together a ethical handbook, a short handbook, which I contributed to as well, and that is now published, and it's on our website and there for policymakers and leaders to look at. It's quite short because we didn't want to make it too long so that people would be put off from reading it. The psychosocial unit was really very active, and already by April the 9th, they had conducted the UWI Rapid Response COVID-19 Impact Survey, But of course, we're not just interested in knowing what's happening amongst our staff and students, but that survey using validated instruments, and which was also had undergone ethical review, was also used and rolled out, for example, in Trinidad, and we intend to roll this out to other countries as well. And we're also participating in similar psychological impact surveys in multi-country studies. But just looking at the survey which was completed on UWE students and staff, and just giving you the highlights of that on this slide, as expected, the students and staff were suffering from a number of psychological concerns during the pandemic period, such as fear of failure, the ability to pursue and achieve educational and professional goals, managing their finances, managing school and work responsibilities, problems with concentration, and the fear of falling ill. And when we looked at the level of anxiety and depressive symptoms, and I've shown it here for students, where 67%, 2/3 of our students, had either severe or moderate anxiety symptoms. Now, this pie chart normally has 4 quadrants, but we actually had no students who had minimal symptoms. They all had either mild, moderate, or severe symptoms. And then for staff, it would be 60% with severe and moderate symptoms. So, these are very high levels, which would merit having interventions, psychosocial interventions, and that has actually underpinned what we have done. So part of the policy response for students who have been caught up in this pandemic through no fault of their own and had to move all their teaching online, they had to move their assessments online, is that if they fail a subject, we will have this grade called fail minus penalty. So there will be no academic penalty if they fail. They would simply need to retake the test again, and then that grade would then apply. And so that takes away the specter of academic warnings or asking students to have a required to withdraw from the semester that was so badly affected by COVID-19. And I'm also quite pleased that we were able to, with the Caribbean Examination Council at the special emergency meeting of COSOD, that we were able to have unanimous endorsement by all regional ministries of education of the waiver of the matriculation requirement, one part of it, which this is the matriculation requirement of what CAPE students normally have to do to get into UWE. Now, we realize that with exams being postponed, thankfully they have been completed now, but even that wasn't certain at the time, that the results will not be in order to allow people to apply and start the semester by August the 30th. So for this semester, we have said that students who have passed at least 2 CAPE subjects at Unit 1 or 2 at grades 1 to 4, who also have the requisite CSEC subjects and are currently registered for Unit 1 and 2 qualify. And what we've taken out is, and have successfully completed. So we're allowing them to matriculate into UWE based on their first year of CAPE, because the second year of CAPE won't have been graded by the time that the semester will start. So this was a policy response based on all the anxiety that we were picking up, not only in our student body, but also in those students who were stuck in this purdah, couldn't do their CAPE exams and didn't know where they were going. And of course, to reassure anyone, members of the public, that this doesn't affect the integrity of UWE's standards, because matriculation is really a minimum admission standard, and other faculties, for example, law and medicine, would be able to establish their own faculty-specific admission regulations that go beyond that minimum admission standard. So this isn't going to lead to a sudden sort of surge in applicants to law or medicine. And moving on to the role of the gender specialist, So it's very important to have a gender lens when you're responding to a pandemic, because you would find that the particularly females would be most affected by the pandemic because they're more likely to lose their job, more likely to have to take on domestic housework and caring work, and they're less likely to be able to rejoin the workforce because of that. And they would also be subject to gender-based violence. And then, of course, there's the whole recovery from and coming out of lockdown, which again, if you don't have gender representation on those committees, you would end up with what happened in the UK, which was a bit of something between a travesty and a joke, where a committee that was all dominated by men, the first 3 activities that they permitted after lockdown was angling, shooting, and what was the third one? I can't remember now. Another very male-orientated activity. So it's very important to have that representation, and we have the experts from the IGDS who are on the task force. And in terms of the economic impact, when you have an unprecedented event like this, the only sort of playbook we have is from 1918, from the Spanish flu. Simulation exercises can be a useful methodology to sort of investigate these complex scenarios. And so we conducted a simulation exercise with our expert from the Sir Arthur Lewis Institute for Social and Economic Studies, which looked at 2 hypothetical Caribbean countries, one being a tourism-dependent country and one a resource-exporting country, which are coming out of a 4-month lockdown. And this underpinned 2 webinars which were organized by Silices, and you can see them here. And finally, in terms of tourism recovery, our expert, Michelle McLeod, who's a real dynamo from the Center for Hotel and Tourism Management in the Bahamas, she worked very closely with the CTO and the Caribbean Hotel Association to assess the situation, which of course is absolutely dire. You would see in the middle of that diagram the downtick from the largest recession since the 1930s in 2008. But look what's happened for COVID. It's just on another scale altogether. And so she has put together a lot of resources which are again available through our website. And she's written a tourism recovery report, because when we come out of this, which we will, tourism is a fundamentally resilient sector. As soon as it's safe to travel, people will travel. We want to reopen better. And so, a key point of the tourism recovery report is to go back to the San Juan Accord for the Open Skies policy. And this would allow the Caribbean, to get away from the traditional source markets. And you can see the problem with the over-reliance on one source market, like the Bahamas with the US. They desperately wanted to open to the US. And when they did so, they were importing a lot of cases and had to curtail that reopening. So we want to diversify with the Open Skies policy so that we can enter negotiations with new markets, and for example, Singapore Airlines and Qantas, and try and reopen better than we did before. And finally, the students, using the information from the psychological impact study on students, they have held a number of these coping webinars where they speak about and have experts on topics like study skills and time management, how to what to do with your children when you're trying to study, and relaxation techniques and that kind of thing. And importantly, just aimed at UWE students, but these could be attended by anyone, in any of the tertiary level institutions in the Caribbean, or indeed anybody, so that they serve a social good. And the webinars and seminars and conferences that UWE TV has held are just legion, and really UWE TV and the marketing department have been tremendous in being able to bring the work of the UE during this pandemic to the public and to our policymakers. There at the top left, we also carry live with an agreement with the World Health Organization, their briefings on Mondays, Wednesdays, and Fridays through our terrestrial TV. And here again, just more of these webinars. Some of these will be campus-based. You would maybe remember that one, COVID-19 Approaching Code Red. That was in one from Mona. It had record numbers of attendees, and I think it was because of the title. It was just so appealing, or maybe so scary. So that concludes my presentation, and right from the beginning, and I have to stress that I came up with this before the Director General of the WHO did. Our motto really is, together we will get through this. And so in our society, with the information that people have, with collective actions, with collective responsibility, everyone working together, we've done a fantastic job up to now, and I'm very confident that we can continue to do so until we see through this epidemic to the end. Thank you very much.
Thank you so much, Prof. Landis. I've always believed that a coordinated approach towards the sharing of knowledge and expertise, coupled with joint action, because expertise and knowledge, research results must be coupled with action. But joint action as one Caribbean university, as one Caribbean, this is what we need to strengthen the resilience of small island states of the Caribbean and to protect both our individual and common interests. Our next speaker, ladies and gentlemen, is someone I take great pleasure in working with. She and I share common interests. She's a chemist, an educator, and a science outreach enthusiast. When you meet her, you will know. She is Dr. Ainka Brown, graduate of the University of the West Indies, Mona, with a doctorate in organic chemistry and lecturer in the Department of Chemistry here in the Faculty of Science and Technology. She is one of our rising stars. Dr. Brown's area of research emphasizes the development of easier, cheaper, and more environmentally friendly ways to put together various chemical building blocks to make heterocyclic compounds with medicinal and industrial applications. She's also very interested in science communication and increasing public engagement and access. And in the last 10 years, she has been actively involved in organizing academic conferences, science festivals, science competitions, and other activities to bring science to a wider audience. It is always a pleasure to work with Dr. Brown, and I invite you to listen to her speak on the topic, Tackling COVID-19 Misconceptions.
Thank you for that introduction, Dr. Singh-Wilmot, and thank you to the Faculty of Science and Technology for giving me this opportunity to join this broader discussion about COVID-19 and our capacity to respond and to recover. So globally, the past few months has been focused on controlling the spread of the virus. Right, so like many other highly transmissible diseases, we know that we can start out with a handful of persons, and then that quickly increases. And then if measures are not put in place, then we can have it ballooning, and then a significant chunk of persons are going to be affected with COVID-19 in a relatively short space of time. And so while we know that most persons are mildly affected by COVID-19, we do recognize that some persons have significant challenges, and that can require hospitalization. And this hospitalization happening in this short space of time can quickly overwhelm our healthcare systems. And not only healthcare systems will be impacted, can overwhelm our healthcare systems. And not only will this impact the treatment and care of affected persons, but that's also going to make it difficult for other healthcare users to access facilities. And so we don't know a lot about this novel virus, but what we do know is that we can minimize contact with body fluids, minimize droplet inhalation, and if we're mindful of being in enclosed areas or touching contaminated surfaces, then we should be able to reduce the spread of this novel coronavirus. And so those things have led to a three-pronged approach of social distancing, of wearing masks, and treating surfaces that are high touch. And so bringing those together has led to a flattening of the curve, and we've been able to, for the most part, control the spread of the disease here in Jamaica by adhering to these strategies. And in so doing, what we've done is limited the number of seriously affected persons at any one time, and so we're better able to cope and manage this scenario. But now we're in a transition stage. Right? Persons are moving from working exclusively at home, they're returning to physical locations. We're navigating the process of opening our borders. Who should we let in? How do we go about doing that? And then, of course, there's that ongoing discussion about the new academic term. How are we going to manage schooling? And so we're in very uncertain times, we're in very dynamic times, we're in very challenging times. But in order to ensure that we do not lose the gains that we've made, we have to be very clear on how we're going forward, and we need to be very sure about the best practices. And if we don't have that clarity, and if we don't have that surety, then we can go back to square one. And so that's why I really want to focus on some misconceptions that are floating around. So I've been asked to tackle some of the COVID-19 misconceptions. Misconceptions, if left unchecked, that it can lead to us going back to a situation that we've just tried to claw ourselves out of. And in particular, the misconceptions I want to focus on are treating surfaces. So how do we go about removing coronavirus from our surfaces? We know that the major mode of transmission is interpersonal. So coming in contact with body fluids, coming in contact with droplets. So when persons are speaking, coughing, sneezing. But surfaces can be a mode of transmission, and that's something that we need to be very mindful of. So if we are not sure about how best to treat our surfaces, then this can make us less effective at keeping ourselves safe. And so what I want to talk about is cleaning, sanitizing, disinfecting. We hear those terms thrown around all the time. Are they all the same? What exactly do they mean? How do we carry out those activities? And then there's choosing and applying products. We tend to reach for products that are branded, that are very front and center, but are other products equally effective and useful? And then there are persons who want to look at chemical-free alternatives. So we'll talk a little bit about that. So sanitizing versus cleaning versus disinfecting. Our major aim is to sanitize, and sanitizing involves reducing germs on surfaces to a safe level. What cleaning refers to is physically removing the dirt, the impurities, the germs. And during cleaning, you don't always kill the germs, but they are removed from the surface. Disinfecting, however, is what is going to kill the germs, and that usually requires the use of a chemical. And so in sanitizing, our two main objectives, we want to break down the protective coat of the coronavirus, and we also want to be able to disable and destroy any of the genetic material, and so the virus is no longer infective. The best approach in sanitizing is that you need to clean before you disinfect. All right, so many of us would just use our disinfecting agent and we would spray the surface and we do a quick wipe and we think that we've done the job. But by not cleaning beforehand, what that does is reduce the power of our chemical to disinfect. So you need to clean the surface thoroughly, get rid of as much dirt, germs, grimes as possible, and then you use your disinfecting agent. And that is helping us to achieve sanitization. What products do we need to use for our sanitizing? Recommended products from the World Health Organization and the CDC and other governing bodies, that we use soap or detergent. Ethanol, also known as alcohol, is good to use, but it must be over 60%. We can use isopropyl alcohol, which is commonly known as rubbing alcohol. That must be over 70%. And then there are the quaternary ammonium compounds, and these are found in a variety of products, both locally and internationally manufactured ones. So we don't have to focus on a specific brand, but we need to look at the ingredients. So looking at the packaging of our cleaning wipes or sprays, once it has quaternary ammonium compounds, then we can use them for sanitizing. How do these things work? Because understanding how they kill the virus can give us a better sense of the best ways to use them. So we're going to use our quaternary ammonium compounds as an example. So we see that for the coronavirus, that outside coat that protects the virus, it is made up of these two layers. And the layers have chains that are stacked tightly together, and those protect the virus genetic material. Quaternary ammonium compounds, once they're sprayed onto the virus, what they do is they disrupt this layer. And so once this layer is disrupted, it means that the protective coating loses its integrity, the genetic material spills out. That is also attacked in a similar manner by the quaternary ammonium compound, and then the virus is destroyed, the surface is sanitized. Similar action happens whether we're using our alcohol or our rubbing alcohol or our soap. They also disrupt this layer, and that helps to kill the virus. Other recommended products are hydrogen peroxide within the 3 to 6% strength that's commonly found in pharmacies or other stores, and sodium hypochlorite, which is known as bleach. And we wouldn't be using the bleach directly. What we would do is make a solution of the bleach. We could use 4 teaspoons in a quart or a liter of water, but the solution must be made fresh every 24 hours. Bleach is so reactive that after 24 hours, it is going to break down and it's not going to be as effective. How do bleach and hydrogen peroxide work to kill the coronavirus? It's a slightly different way from how our quaternary ammonium compounds and soaps react. What the bleach does, it transforms the structure of the coating of the virus. And in transforming the structure, the coating can no longer hold together. And so you're going to have the virus splitting apart. The genetic material is going to be exposed, which also gets attacked and changed by the bleach or the hydrogen peroxide, and that results in the death of the virus. We've heard suggestions about using vinegar, or that if you have some alcoholic beverages like your wine or your beer on hand, that those could be useful. Not recommended. Those are generally too dilute to do anything. Unless your alcoholic beverage is over 130 proof, it's not doing anything. And so you would pour it on your surface and the virus is going to remain intact, and it's still there and it can be infective. So we would focus on the recommended cleaning agents. Apart from choosing the correct product, you need to have the proper application, and you need to thoroughly wet the surface and wait 1 to 2 minutes, and that would be enough time for these chemicals to interact with the protective coating and to break it apart and to kill the virus. Most importantly, we need to avoid mix-up. We like to mix our cleaning compounds in the thought that that would make them more effective, supercharge them. But in fact, what we're doing is reducing the effectiveness of the compound, and we're also producing hazardous byproducts. So some examples: if you mix bleach with vinegar or bleach with toilet bowl cleaner, what you're going to generate is chlorine gas. All right, that is toxic to you, and that's not going to be as effective as the bleach in doing what you want it to do. Also, mixing bleach with cleaners like ammonia will generate compounds known as chloramines, which are irritant and highly toxic. So what you want to do is use the disinfecting agent as recommended on the packaging. All right, persons are fearful of chemicals. We have this chemophobia where we think that anything that has the name chemical is bad. We know that's not true. But for persons opting to use different methods of cleaning, We have those that don't involve chemicals, such as steamers. They can be a useful addition. What we have is supercharged water molecules. So they're steam, they're high energy water, and they're going to break apart our coronavirus. And that would be more useful for soft material that is harder to treat with your quaternary ammonium compounds or your bleach or your soap. Also fairly popular is UV light. We see that some companies have been selling handheld ultraviolet light. The problem with that, it has to be a specific type of UV light. So you have to be very careful that you're getting UVC UV light with these products, and they can be very damaging to eyes and skin if they're not used properly. So these would be better in the hands of professionals who know how to take the necessary safety precautions. And this high energy UV light will also break apart the coronavirus coating. One area of active research is copper containing surfaces. So we do know that copper ions have the capacity to destroy germs such as bacteria and viruses, and they are effective against coronavirus. However, this takes several hours. So persons who are busy selling things like no-touch door openers that are made of copper, so you can use it to hold surfaces instead of your hand, you have to be mindful that the coronavirus, if present, is going to be on the copper for several hours. And so that is also going to need to be sanitized. So while it can be a useful tool, it is not a fail-safe, and it's not a replacement for our disinfecting agents. Also, we see where persons are replacing fixtures with brass or bronze, so door handles and taps, other high-touch surfaces, with those made out of brass or bronze because of their copper content. And those can be useful in areas such as hospitals and schools that have a lot of traffic going through, but they also are going to require sanitization to be completely effective. All right, so just to recap, the 3 C's of coronavirus sanitizing: we have to choose our products wisely, we have to apply them correctly, and most importantly, they need to be consistently used. So there's going to be a high frequency of sanitizing as persons interact with these surfaces. So it's important that we tackle any misconceptions, because that helps us to better manage the pandemic and to move forward. And here are some links for information that you can Here are some links for sources that you can go to if you need information to answer your queries as we continue to try and keep the curve flat.
Thank you so much, Dr. Brown, for a simple and informative presentation, which I am sure resonated with all our viewers as it resonated with me. You know, when I say, Dr. Brown, I feel it in my bones. COVID-19 presents a clear health and economic challenge to all of us. But disinformation will impede any response to this crisis and ultimately put people's lives at risk. We live in a chemical world, and as a chemist, I know it myself. And we must use these chemicals with respect. We must show them respect if we are to derive the benefits from them, and at the same time minimize the risks associated with their use. Thank you once again. Now, our final contributor this afternoon was strategically reserved for this point in the forum because her energy and youth, coupled with her substance, will wake up any audience, even one that has sat through 5 other presentations. Ms. Danielle Mullings, ladies and gentlemen, is the Guild representative in the Faculty of Science and Technology. Danielle is a multidimensional software engineering student who is said to be one of the field's brightest young minds, and who believes strongly in the power of tech and innovation in edifying society. Danielle aspires to become a world leader in technology and is also passionate about documentary making, which she sees as the gateway to cultural retention and preservation of regional identity. Her natural affinity for leadership and youth empowerment has brought her in service on youth councils, both locally and internationally, representing the voice of young people in technology, education, national issues, and tech for health. I now invite Ms. Danielle Mullings to make her contribution on the student response to COVID-19.
All right, thank you, Dr. Singh-Wilmot, for that introduction. My name is Danielle Mullings, and I am the president of the FST Guild Committee, otherwise known as the Faculty of Science and Technology's representative on the Guild. So as we navigate through a time of immense change worldwide, our students are dedicated to enhancing the COVID-19 response. So on behalf of the Guild Committee and the students overall, it is my distinct pleasure to speak a bit about what our response to COVID-19 has been like. It's the Faculty of Greatness, it's been a great year, and it's going to be a great year. So to start off, we have been discussing for the rest of this series a variety of responses to COVID-19, right? We looked at the capacity of the faculty to respond, demystifying COVID-19 screening, we've looked at misconceptions, we've looked at the regional response, and now we want to bring it home to what are the students doing? Because the students are of paramount importance to the functioning of any faculty, the functioning of any educational institution. So what are they doing with what they've learned from their professors, from their teachers, from their classmates? What is coming from the students? And to start off, I want to say, what is an FST student like? What are some adjectives we can use? And so we call SciTech, or we call FST SciTech, so I'll be using that term interchangeably. So I'll say SciTech is comprised of innovative, technical, creative, passionate young leaders who are eager to edify their communities, and they're thus able to contribute in a myriad of ways. I would also say that we're united by that passion for STEAM, which is science, technology, engineering, the arts, and of course, mathematics. So coming together, you have students with that kind of technical background, that kind of passion, now coming together, and they've been thrust into a global pandemic with a lot of uncertainty, a lot of rapid change. And so the question becomes, if they have that much potential, then what is the role of the student? What is the role of young people in building back our communities and building back our country regionally, nationally, regionally, and internationally, of course? So I've come up with 3 main points that I would put it under, and this is from speaking with students, and we also did a survey to ask, like, what have you been doing? And so we identified 3 main ways. One is innovation, the second is digital education, kind of like digital literacy, and the third is advocacy. So we're going to go right into the first one. So I've put a quote up on screen, which is basically saying that change inspires innovation, if you will. And so our students have been thrust into a world that is rapidly changing because of the COVID-19 pandemic. And so innovation is a must coming out of it. So let's see, what have our students been up to? Coming out of the departments of physics and computing, our students developed a healthcare gadget. And this is essentially a patient's vital monitoring system. Given that the COVID-19 pandemic may cause hospitals to be overflowed or have too many persons as opposed to that which it can accommodate, we're having now a gadget that can actually monitor patients from a distance and then feed their vitals information into whichever database, hospital, or information center that it would be needed for. So what you're seeing is our students have the capacity to innovate in the midst of a pandemic. So moving from here, what we're seeing is that our students have the capacity to identify issues, problem solve, and then execute on it. So our second point is digital education, which is basically digital literacy. And when we speak to this, it's interesting because it's somewhat of a role reversal. Because the concept of a student is that you're here to learn, you're taking in information. But what we're seeing is that COVID-19 has been a grand catalyst for technological advancement across the Caribbean. Like, this is the first time you'd have wide-scale online learning, work from home. All of these are now common concepts that weren't common 4 or 5 months ago. And you look at it and say, our students are uniquely positioned as digital natives, someone who has a lot of exposure to technology already. Maybe not every single person, right? But a lot of our students already have exposure to technology, whether it is for what you've been working on for your classes. And it now puts them in a position where they can teach. They can thus educate a lecturer, let's say, on how to use Zoom or how to use a Blackboard Collaborate system. And so the capacity of our students to be digital educators is a whole realm to be explored. So there are many different aspects of digital literacy. There's, how to use a computer, setting up an email, many things that we may take for granted because we do it every day. But there's a large percentage of persons in our country, in the Caribbean, in the world overall that have never been exposed to some of these technologies before. It's always that face-to-face interaction. And so our students can help here. So I've brought up on screen, this is Nathan Downer. He is the past president or outgoing president of the UWI Computing Society. And I worked with him to basically create some videos. And these are like tutorial videos for how to use Blackboard Collaborate, because that's what the university was moving towards. And then these were, as well as how to use Zoom. And then these videos were now circulated across the campus. I even saw some students from St. Augustine message me and say that they were watching to see how to use Blackboard Collaborate. But essentially, again, this capacity that our students have to be able to teach and to be able to share some of that digital knowledge as we move into the technological age. So here we have a snippet of the video from Nathan Downer, and he's explaining how to use Zoom properly, some of the features that are available to you, and how this knowledge can enhance your use of the online space.
Hi, my name is Nathan Downer, President of the UWI Computing Society, and today we're going to be looking at how to use Zoom as a student. Now, one of the first things you want to do before joining a meeting is making sure your mic is muted, so you don't disturb anyone. We can do this by clicking on the settings cog, going to audio, and then selecting mute microphone when joining a meeting. And of course, the same can be done on your smartphone. The next thing we're going to look at is how to join a Zoom meeting. The first way is with a meeting ID. This meeting ID will be provided for you in the course container on our VLE for the respective course. Ensure that the name you use is the same one you use to register with the school so that you can be identified. When you click on the link, it's going to take you to the browser, where it will ask you to allow it to open in your app. Now remember, have your mic muted when you're entering the meeting. Okay. So now on to changing the views. Zoom has two main views, the speaker view, which is the default one, and the gallery view. Speaker view allows us to focus on the person who is doing something at the moment, for example, the one speaking or sharing their screen. And gallery view will allow you to see as many participants as your device specs allow. Now, along with the two views mentioned a while ago, the mobile app has an extra mode called Safe Driving Mode. When it comes to communication in Zoom, you're not limited to just audio and video. But if you'd like, you can also use a chat to reach out to everyone in the meeting, or individuals like your lecturer, who would likely be the host of the meeting. Now, if you'd like to audibly ask a question, the protocol is that you raise your hand and wait till you're identified, to then unmute your mic and speak. You can raise your hand by going to Participants, and then clicking on Raise Hand. The same can be done in the app by hitting the More button at the bottom right and then clicking Raise Hand. You can also use the chat from the app as well, clicking More and then on Chat. Now, if for some reason you'd like to share your screen with the class, whether it is to show an assignment or a particular problem you're having, you can do this with the button at the bottom. Here you can select from any one of your open windows or your entire desktop. Let's open Microsoft Word. You can stop sharing, you can pause sharing, or you can also annotate and draw on the screen. This helps to provide a very rich collaboration experience, as your teacher can also annotate and make corrections and suggestions. And that is how we use Zoom. Thanks for watching. Stay safe.
I did a video now for the Blackboard Collaborate as well as general online learning tips. So students were able to look at this video now and say, okay, this is how I access my class. This is how I raise my hand virtually. This is how I raise a concern in the online virtual classroom space. And so again, I guess this would be an intersection of technology and then media and communications and being able to also create videos and to assist in that learning process. So here we have a snippet of that video.
Hi Pelicans, my name is Danielle Mullings, a UE student just like you. I will be helping us all learn how to use the Blackboard Collaborate platform. Let's go! To access a Blackboard Collaborate course room, you first have to log on to ORVLE. So navigate to the ORVLE webpage and log in. Now that we've signed in, you must navigate to the course that you'd like to access the Blackboard Collaborate course room for. For me, that's Phone 1014, Crit. Now that you're on the course page, you need to find the link to the Blackboard Collaborate course room. This normally has an icon that looks like a green puzzle piece, or it's the Blackboard Collaborate logo. This will now load a list of sessions. The main course room will be the first session. You look here to see if it's unlocked, which means you can enter the room, or if it's locked, which means you cannot enter the room. For most courses, your lecturer should let you know what frame of time before a class starts that you can enter. One important aspect to note is that a course room is separate from a course activity room. Your course room is more likely where your main lectures will take place. However, for your smaller tutorial classes, they will be in a course activity room such as these below. For many lecturers, your main course room will always be available. This may not be in some instances, however, for most. For your specific tutorial classes, however, you must access it at the specific time listed below the class. However, once it is unlocked, you can enter, so click. And then select Join Course Room. It will then load the Blackboard Collaborate interface where your class will now take place. We'll go through the various sections of this interface in another video. From this page, you are also able to access class recordings. If you wish to do so, select the hamburger menu icon in the top left-hand corner. Now select the Recordings tab. As you can see, there are currently no recordings available. However, once a lecturer has finished a class and makes the recording available, it will show up on this page. If you'd like to go back to access your classes, simply select the hamburger menu and then Sessions. Now you have a list of all your course sessions again. That's all for this lesson. My name is Danielle Mullings and thanks for watching. Have a great class.
All right. So I also want to speak to the Teacher Success Program. I worked with a company that the Ministry of Education partnered with in trying to continue learning in an online manner given the COVID-19 pandemic. And what I found interesting about it though is that our team had 4 persons, and 3 of us were university students. So I'm from UE, someone from NCU, and someone, again, so 3 students put together and led by a manager. And we were able to execute a 2-month-long teacher success program for teachers in Jamaica as well as teachers in the Bahamas. And so it would have comprised of weekly webinars. We did everything from the 21st century skills for a digital educator. How can teachers learn to advance themselves during this period? We also did one-on-one sessions. So a teacher may say, Danielle, I want to learn more about how to use PowerPoint. How do I put a presentation together? So we did a series of seminars, like hundreds of teachers, especially in Bahamas. The class size was very large, but again, just alluding to that capacity of our students to teach what they know and to impart knowledge during this time as everybody is moving towards a technological age. And moving from there, I'll also mention the Zoom refresher sessions that we did. And essentially, there is a 1 month break between the 1 month break allowing for the university to prep teachers for online delivery. And so when school started back, students were like, whoa, I've been out of class for a month now. I really don't remember what was going on. And so I was able to organize with some of the postgraduate students to say, could you help us out here and there? We set up an online session and students are able to come on, revise what they did the month before and kind of get ready and back in the zone for online learning. So there's a range of ways that we can really contribute during this pandemic. And I want to say that this is by no means like an extensive list of what our students are doing, because there are students running scholarship pages online, virtual CSEC and CAPE study sessions, They may look at mental health awareness. They're looking at so many different issues in their own way, and a lot of it is aided by the technology. And I specifically as well would like to say there's one student who has over like 20,000 followers on his CXC or CAPE study guide page, and he is aiding thousands of students across the Caribbean, literally. His website crashes every now and then because of how many students are trying to access it to get some of his tutorial videos, or he's helping out, as well as just posting content that could help students during this time. So there's a range of applications and ways that our students are responding to COVID-19. Some of it may have been started from before, but a lot of it was also created during the crisis, during the midst of challenge. And so the last point I'd like to speak on is advocacy. And I would like to say that advocacy doesn't always take the traditional form, getting up on stage and speaking and that, the normal way that you would see an advocate. And there are many movements that would have come out over the COVID-19 period. I like to call them COVID-19 induced, because I think COVID showed a lot of the disparity and a lot of the divide in the world in various areas, and students were taking to, maybe it was social media, maybe they were making their own videos, whatever it was, they were taking to lend their voice to these issues. And so I believe that from the advocacy perspective, our students are able to contribute to or lend their voices to advocating for equitable healthcare, whether around the world or locally, advocating to hold our leaders and our peers accountable for the change that we'd like to see in society, because COVID showed so much disparity. And the third point would be to advocate for the digital divide, because this is a grand reality, and many students in the midst of the pandemic as well were faced with not being able to continue their studies because they didn't have access or reliable access to internet, or they didn't have a device or whatever it was. And I saw many students coming out to say this is a real issue, not just for students, not just at this level, but across the entire scale. If we're moving into a more technologically advanced society, we need to have the digital divide be lessened out a bit. So there are many issues that our students can advocate to. Their voices are important, and it doesn't matter if it doesn't take that traditional form. Maybe it is social media, that's fine. But we're speaking to the capacity of our students to speak up and be informed about issues and lend their voices to universal change. And I speak to that in this quote here. This is from World Youth Skills Day, and I basically said the exact same point, that social media allows us to connect on a wide scale. A lot of us allow us to put our voices together as a collective and say, this is what young people believe, and here is our opinion, our perspective, and please take it into account. So moving on from there, again, these 3 points, innovation, digital literacy, and advocacy, are just 3 ways that students can help. 3 ways that we've identified, but there are many other ways that I'm sure can be explored. However, whichever way it is, our students are the future, and our students are helping in building back our country, or our nation, our region, and the world overall. One small change makes a ripple effect out. So I want to end with a message, basically, for any student or any young person that may be watching. It comes from one of my favorite quotes, which is, if your actions create a legacy that inspires others to dream more, learn more, do more, and become more, then you're an excellent leader. So I'm encouraging you to get involved, meet new people, believe in your potential to be great, trust in your astronomical aspirations, and set foot on this journey with a centered and focused approach. We believe in you. Some of our students are already doing it, and you can most definitely do it too. So identify what are the issues in maybe it's your community, maybe it's in your household, or maybe it's in your school, whichever environment you're in, maybe it's your church group, whichever field or specific set of persons that you're reaching out to. If you can come up with some sort of solution, even if no matter how small it is, try your best to execute and maybe find like-minded persons to put together and create that change. But you're most definitely capable of doing it. So that's basically the end of the presentation, and I'd like to end just with get connected with us, the FSTGC, or the Faculty of Science and Technologies Guild Committee. We're literally on like every social media platform you can think of. There's YouTube. All the links are on screen, and we'll also have somebody post them in the comments right now, so you can click and directly go there. But we're on YouTube, LinkedIn, Facebook, Instagram, Twitter, the whole works, and we have an amazing PR team that will reach out to you immediately if you'd like to get connected and stay in touch. So that being said, thank you for listening. Again, my name is Danielle Mullings, and enjoy your day.
What an absolute pleasure it is to listen to this young lady. Now, Danielle's power, her passion, her pride in her craft, and those whom she represents was obvious in her presentation. And I would love her to be able to talk some more with some of you young people out there in the audience, so some of that can continue to rub off on all of you. That presentation highlighting science in action, yielding innovation from our young people to fight COVID-19. As I listened, I felt a regenerated spirit of hope as I saw the future of science, and indeed Jamaica's future, in good hands. But Danielle, it would be nice if we could take the information coming out of Parris's work at MGI and create an app that we could all have on our phones. As we move around the island, when I come to Lyew-Ayee, I can check my app to know, how many cases are in Lyew-Ayee, and that would guide my actions in Lyew-Ayee and possibly help us in some sort of control against COVID-19 as we move about our activities. I know it is in the rest of the world, and I feel it's coming from you and your team here in the student body at FST. So all that is left for me to do now is to thank all of you who have helped to make this event possible. First, the speakers, Dr. Andre Coy, who established that the Faculty of Science and Technology here at UWI-Mona is advancing the mission of science to make people's lives better with interventions, putting science in action, and fighting COVID-19. Dr. Sandra Jackson, who demystified COVID-19 screening, building understanding of a process which is critical to preventing transmission and fighting this virus. Dr. Parris Lyew-Ayee Jr., Managing Director of Mona Geoinformatics Institute, for all that you've done to help Jamaica track and predict COVID-19, and for taking the time to explain it to us today. You and your team have established that every hour, every minute, every second, science is in action in Jamaica, fighting COVID-19 in real time and giving us data which can help us to protect the most vulnerable among us, inform policy decisions, and guide our daily actions. Prof. Clive Landis, Director of the UWI Task Force on COVID-19, has shown the very important initiative at work to harness the expertise and resources of the UWI and direct a Caribbean response to COVID-19. We are stronger when we work together. Dr. Ainka Brown, who broke the science right down and tackled some of the misconceptions that are out there, arming us with credible information, arming us with the science to fight COVID-19. Finally, our shining star, FST Guild representative, Ms. Danielle Mullings, who showed science being put into action by UWI FST students. Thank you all for your tremendous contribution to this forum. I want to also thank the hardworking team that worked to bring you this event, the entire external engagement committee in the Faculty of Science and Technology, led by Dr. Andre Coy. I want to especially thank Ms. Terry-Ann Collins-Frey and Mr. Maxwell Williams for their exceptionally hard work. The team at UWI-TV for making this production possible. And thanks to all of you, ladies and gentlemen, for joining us. I am Marvadeen Singh-Wilmot, your moderator. Remember to join me here on August 5th for round 2 in fighting COVID-19, Science in Action. All the best to you, and remember, keep safe.